The focus of this presentation is red flag sepsis. The aim of the presentation is to provide a clear understanding of how red flag sepsis differs from the official definition of septic shock, its epidemiology, its pathophysiology, and how paramedic practice is key to early recognition and early treatment. The term sepsis derives from the Latin meaning rotting and from the Greek word sepian meaning decay. So what is septic shock? Septicemia was first identified by the physician Avicenna as rotten blood and tissue with fever. The term shock denotes hyperperfusion caused by circulatory compromise which fails to respond to fluid resuscitation. According to the Third International Conference for Sepsis 2016, the officially recognised definition for sepsis is that it is caused by a deregulated host response to infection, leading to cellular, hematological and neurological compromise, which causes life-threatening organ dysfunction and ultimately death. It is important to note death itself is a result of the host deregulated response and not the infection. The term red flag sepsis was determined by the UK Sepsis Trust, NHS England and the Royal College of Physicians 2015. It is adapted from the official definition to provide instead a checklist of clinical features using which pre-hospital clinicians, paramedics, can identify a high index of suspicion regarding sepsis and the threat of organ dysfunction, which cannot readily be confirmed pre-hospitally in the absence of diagnostics and blood cultures. According to the UK Sepsis Trust, there are approximately 250,000 cases of sepsis in the UK alone, 44,000 of which will prove fatal. That's more than lung cancer alone and more than breast, prostate and bowel cancer put together, which costs the NHS an estimated £1.5 to £2 billion a year. The UK Sepsis Trust reports risk factors for sepsis are higher in certain groups based on age susceptibility, the very old and the very young, the immunocompromised, whose immune systems may be compromised due to comorbidities, invasive procedures such as PICC lines, fistulas or catheters, or immunosuppressed by medication, those who have undergone recent surgery or trauma, those who have sustained an injury where the body's basic barrier, skin, is broken, or pregnancy-related complications such as medically assisted deliveries, premature delivery, or mothers still experiencing PV bleed soon after birth. The EPIC-2 trial 2009 examined 14,000 patients, identifying 7,000 with sepsis, admitted to over 1,200 intensive care units spanning 75 countries, a very comprehensive study, finding that the three primary causes of sepsis worldwide to be respiratory, abdominal, and bloodborne. Sepsis has two broad causes: infectious, linked to internal or external pathogens, and non-infectious, linked to injury, burns, damage. So just how does the body go from a normal response to infection to a deregulated state of septic shock? Certain immune cells carry pathogen recognition receptors, which trigger alarms in the presence of pathogens or injury. They relay intracellular messages in order to elicit inflammatory responses. Pathogen recognition molecular patterns, or PAMPs, are alarm molecules triggered when the host system is breached by an internal or external pathogen. For example, lipopolysaccharides, also known as endotoxins, which are released by the cell walls of gram-positive bacteria when attacked by a pathogen. Damage recognition molecular patterns, or DAMPs, trigger alarms when the host system is breached by damage or injury. For example, high-mobility group box 1s are released by dead or dying cells. The body's response to infection sees it develop fever, vasodilation, vascular permeability, and cytokine release which allows for pro- and anti-inflammatory responses. Internal pathogens such as tumour necrosis factor, interleukin-1 and interleukin-6, as well as external pathogens such as lipopolysaccharides, trigger febrile responses in the hypothalamus. The fever is made worse by the body's use of stored fats to fight the infection, and further exacerbated by anaerobic metabolism, which simply adds heat. Fever is one of the cardinal signs of sepsis. Progressive vasodilation, however, causes heat loss and eventually hypothermia, which Kishimoto et al. Found to be linked to higher mortality. Bradykinins and nitric oxide facilitate vasodilation, which allows for a greater volume of traffic of fibrins, macrophages, and leukocytes to the site of infection. However, this causes relative hypovolemia, hypertension, and heat loss. Leaky capillaries enable the fibrin, macrophages, and leukocytes to filter through to the site of infection and injury. However, they also leak fluid interstitially, causing edema, hypoperfusion, and hypotension. In response to the leaky capillaries, thrombins release coagulation cascade in an attempt to limit vascular compromise by clotting. However, the continued vascular compromise means widespread utilization of clotting factors and large-scale intravascular blood clotting, known as disseminated intravascular coagulation. Having examined the pathophysiology of sepsis, we can see how this progresses to organ dysfunction and the 6 clinical features of red flag sepsis, as advised by the UK Sepsis Trust. Slurred speech owing to the cerebral hypoperfusion, extreme shivering due to the initial febrile response, which may later develop into hypothermia due to vasodilation and heat loss, the passing of little or no urine, either due to urosepsis being the cause or due to renal compromise caused by coagulation in renal capillaries, severe breathlessness or ARDS, adult respiratory distress syndrome, due to coagulation in the tiny capillaries of the lungs, combined with interstitial fluid which causes edema, and skin mottling due to disseminated intravascular coagulation. With this level of organ dysfunction and shock, the patient will likely feel as though they might die. How does this relate to paramedic practice? Seymour 2012 reports ambulances attend more sepsis calls than heart attacks and strokes, with patients conveyed by ambulance likely to be more severely septic than those who self-convey, and up to 50% of patients conveyed by ambulance ending up in intensive care units. Therefore, pre-hospital early recognition and early treatment are pivotal to improving outcomes. Because of the limitations of the pre-hospital environment and time constraints, the UK Sepsis Trust, NICE guidelines and Royal College of Physicians have adapted the International Sepsis Diagnosis and Protocolised Management of Sepsis in Hospital. Their recommendations are that any pre-hospital clinician should suspect and screen for potential sepsis if a patient presents as a patient who looks unwell, a patient with a new score of 5 or more, or a patient with identified or potential infection. The National Early Warning Score was developed by the Royal College of Physicians in order to identify time-critical patients in the pre-hospital or acute emergency setting. It has been universally adopted by ambulance trusts in England to enable the early recognition, early treatment of deteriorating patients. The new score, as we can see, uses 6 clinical markers to identify a deteriorating patient at risk of clinical shock and organ dysfunction. There is a revised edition, New Score 2, which is yet to be universally adopted. Once early recognition of sepsis or septic shock is established, the Sepsis 6 bundle forms a protocolized approach to early treatment involving 3 diagnostics and 3 treatments, and it is based on Rivers et al.'s 2004 study looking at early goal-directed therapy which has been adopted by the UK Sepsis Trust in coalition with the College of Paramedics and NICE Guidelines 51. For the paramedic pre-hospitally, the focus is giving oxygen, intravenous fluids, and antibiotics. Surviving sepsis guidelines advocate high-flow oxygen for sepsis patients, the therapeutic aim of which is to counter tissue and organ hyperperfusion, metabolic acidosis, where oxygen demand is not being met by oxygen supply in a compromised patient. The key paramedic intervention in the surviving sepsis guidelines is fluid resuscitation in order to counter the tissue and organ hyperperfusion, hypotension, and to improve cardiac output. The clinical indication for fluid resus in the protocolized care of sepsis is where a patient has a mean arterial pressure of less than 65 millimoles of mercury or 40 millimoles of mercury below their norm, with the therapeutic aim of raising blood pressure caused by vasodilation and vascular permeability. The fluid of choice is crystalloid 30 milligrams per kilo. The surviving sepsis guidelines specify early administration of broad-spectrum IV antibiotics as a strong medical recommendation based on moderate evidence. However, best practice is to obtain blood cultures first in order to identify the pathogen and tailor treatment for improved outcomes. Therefore, they are not currently used by UK ambulance service trusts. To conclude, sepsis is increasingly presenting itself in the pre-hospital environment. Therefore, key paramedic interventions are early recognition, early initialisation of treatment, of which IV fluid resuscitation is key, and timely transfer to definitive care in order to improve outcomes for sepsis patients.